Good afternoon. My name is Bill Tazinski, and I am the member of the program committee for the Joseph Priestley Society of the Science History Institute. And I'm pleased to welcome you to our April and final meeting of the 23-24 season. And we're thrilled to have Squealing and Healing on xenotransplanting kidneys from pigs to people. And our two presenters will be Dr. Jayme Locke, Professor of Surgery at the University of Alabama, Birmingham, and Dr. Jonathan Marino of the University of Pennsylvania, where he's a professor of ethics and bioethics. And while we're on, please, if you have any questions, do put them in the Q&A or chat box, and we'll monitor them and come to as many as we can at the end of the program. Dr. Locke will speak first, and then Dr. Marino will add his comments, and then move to the Q&A. And I will turn the podium over to Dr. Locke and let her begin her talk.
You're muted. Dr. Locke, if you could.
Now you can hear me. Can you hear me okay?
Perfect, thank you.
Great. So excited to be here today to talk to you a little bit about xenotransplantation. I love the squealing to healing, and hope to share with you a little bit about some of the things we've been doing, really trying to get us to a phase 1 clinical trial. And I think a lot of what I'm going to show you today was really leveraged to make this first compassionate use of a pig kidney into a living person happen that occurred at Harvard just a couple of weeks ago. So just a lot of exciting work. All right, so here are my disclosures. I think the most important is that I will be discussing an investigational use of what's called the U-kidney. It is not currently FDA approved, but that's the genetically edited pig kidney that we've primarily worked with. So just to back this up for everyone and why this matters so much is that we have long discovered that kidney transplantation, in fact, is the gold standard therapy for end-stage kidney disease. In fact, it is the cure. And I think every study that's ever been done has shown that compared to dialysis, receiving a kidney transplant is associated with a substantial survival benefit. And you can see that depicted here in this graph, where anything below that dotted line suggests that kidney transplantation is better than dialysis. But what we know is that, in fact, there's an organ shortage. And so if you look over time, our transplant curve has been relatively flat. At any given time in the United States, we have between 80 and 100,000 individuals waiting for a kidney transplant. We only do about 25 or 26,000 kidney transplants each year. And if you back that up further, what you'll learn is that there are 37 million Americans actually that carry a diagnosis of chronic kidney disease, and about 600,000 to 800,000 at any given time have kidney failure, and yet we only waitlist 80 to 100,000, and we only transplant about 25,000. So not surprisingly, mortality is quite high. In fact, of those who are actually waitlisted, 40% will be dead within 5 years of waitlisting. And so this gap between supply and demand, this organ shortage, is in fact a lethal problem. It's refractory, it's severe, and we would argue that it needs a radical solution. And I think the federal government agrees. So the first time in American history, there was an executive order issued on advancing American kidney health. This happened in 2019. And one of the things that the government encouraged was the development of an artificial kidney. And we would argue that xenotransplantation represents that. So you might ask, why do I call this the impossible with that P capitalized in there? And it really references the chairwoman and founder of United Therapeutics, who's really been, I think, a pioneer in xenotransplantation, who described driving an axe between the M and the P and saying, no, I'm possible, anything's possible. And so that's really been the motivation. When I first got involved, I had a lot of questions, as you may as well. So for example, why a pig as the source of the kidney? I think it's important to note that it's really related to three main factors. One, pigs are scalable because they reproduce quickly. So they have about 3 litters a year, and they produce about a dozen piglets per litter. They also grow very quickly. So they're born about a kilo, and by 6 months, they're upwards of 150, 160 kilos. And so they can grow large enough to have kidneys that recapitulate a human adult-sized kidney. They also are quite durable. So if you look at pigs outside of the food chain, they live upwards of 30 years. So in theory, their kidneys should last just as long. And then interestingly, they do have kidney function that is similar to humans. That's what this table here is showing you. If you look at the glomerular filtration rate, for the average human with 2 kidneys, it's 130 cc's per minute. And for the average pig, it's about 126 to 175 cc's per minute. And for context, if you want to be a living kidney donor, you have to have a GFR of 90 cc's per minute for us to feel like you can give away 1 kidney and have enough residual kidney function to support you the rest of your life. So without question, pigs have sufficient glomerular filtration for an adult human. So why UAB, and why have we been so interested in xenotransplantation, and why should it really matter to us on a larger scale? So I mentioned the gap between supply and demand. I also want to mention issues around health equity. So if you look at the graphic in the upper left-hand screen, you can see that individuals who self-identify as African American or Black have end-stage kidney disease incidences that are almost 3-fold higher than their white counterparts. I'll also show you that, in fact, the prevalence of end-stage kidney disease varies widely with where you live. And you can see that dark blue are areas with the highest rates of end-stage kidney disease. It's right where I live in the state of Alabama. It overlaps with the stroke belt, the black belt, etc. And so, in fact, we have huge disparities. They're on our doorstep. And when you look at geographic spatial clustering, what you'll see is these royal blue areas are areas that have low transplant rates but high end-stage kidney disease burden. And that makes sense because if you have high disease burden, that certainly drives your demand, but it also decreases your supply because if you have kidney failure, you can't exactly be a kidney donor. And I think from our perspective, we really see xenotransplantation as an opportunity to actually be able to achieve health equity in transplantation. So what have our guiding principles at UAB been with regard to exploring xenotransplantation? The first is we think the biggest threat to patient safety in both xeno and allo meaning human-to-human transplantation, is over-immunosuppressing patients. Because when we over-immunosuppress people, they end up with infections and other complications. And we think you can best avoid this by doing a compatible transplant, meaning having the tissues actually match. We also think that compatible xenotransplantation does not need to be achieved in a non-human primate or an NHP before we advance to living people. We think that you need to understand pig kidney physiology in a human model in order to ensure safety. And we also think we need to be able to assess zoonotic transmission risk in a human model before we move into living persons. And so our overarching goal has been to advance compatible pig-to-human kidney xenotransplantation towards the clinic by really answering critical safety questions. So here's our pig kidney. This is the genotype. It's a 10-gene edited pig kidney. We have knocked out 4 critical genes. 3 are carbohydrate antigens specific to the pig that have been responsible for early hyperacute rejection. The 4th is the knockout of the growth hormone receptor designed to keep that pig kidney from outgrowing its new human source. And then we've inserted 6 human transgenes designed to help regulate the human immune system to prevent early rejection. So what then are some key questions that we wanted to answer before we think about offering this to a living person? The first is really understanding what the optimal immunosuppression regimen might be. And it's important to note that a lot of work to date has been done in the pig to non-human primate model, but it's important to note that it's really been a model of incompatible kidney transplantation. And what I mean by that is that these xenotransplants have been performed across what we call a positive cross-match, meaning the pig tissue did not match the non-human primate tissue very well, setting them up for pretty early and aggressive rejections. So if you look at the figure on the left, it's looking at non-human primate sera, tested against that triple knockout background that I told you was so critical. And what's important is that the frequency of a positive cross-match, meaning the tissues don't match, is 100%. And even if you pull out sort of the least incompatible of these, you can see that not surprisingly, graft survival is not that great, such that at 100 days, only about 10% of the non-human primates are actually still alive. And why might that be? Well, it's because the genetic editing that we've done has really been designed to improve compatibility for humans, not non-human primates. And in fact, non-human primates and humans are in fact immunologically distinct. And these graphs here demonstrate that. So if you look here, these are flow cross matches, and the goal is to get these little dots down here in the left lower box. That would be the negative equivalent of a negative flow cross match, meaning a good tissue match between the genetically edited pig and its recipient. So across the top, we're looking at human sera, and first we're looking at wild type, the WT, and then we move from that to a single knockout, double knockout, and then a triple knockout. And you can see it's not till we get to a triple knockout that humans begin to have negative cross matches with these pigs. But when you move down a graphic and you look at non-human primates, you can see with the triple knockout, there's no non-human primate that actually has a negative cross match. And in fact, the double knockout background's probably better. And then the lower graphic is looking at the same thing. It's just a different kind of cross match. It's called a cytotoxic cross match. And anything below that dotted line is equal to a negative cross match. And you can see it's really only a human that ever had a negative cross match, and that was to that triple knockout background. So because of this, in the pig to non-human primate experiments, people have had to use what we call non-standard immunosuppression. And these are drugs that are not currently FDA approved. And they're having to give them a lot of medication to overcome these positive cross matches. And so not surprisingly, we've seen early infections. And when that happens, you have to decrease your immunosuppression, then you see a rejection, and then the graft and the non-human primate is lost. And so we've really struggled to demonstrate consistent long-term function in the non-human primate model. It's also important to note that the non-human primate model can't answer certain questions. For example, like transmission of zoonotic infections. Why? Because non-human primates don't actually have the receptors necessary to contract things like porcine endogenous retroviruses known as PERS. So our group wanted to go about answering key safety questions. And the first is really around this whole cross-matching thing. In standard human-to-human allotransplant, a cross-match is required before you go to the operating room. And the goal is to prevent what's called hyperacute rejection. And that's where when you sew the kidney in and you restore the blood flow, there are preformed antibodies in the circulation that immediately attack the kidney. It clots from the inside out, turning black, and is immediately rejected. And here's a picture of a hyperacutely rejected kidney. Well, prior to our work, no such cross-match had ever been developed. So to do this, we needed to actually develop a preclinical human model. And this is really where this idea of leveraging human brain death came into play. And this is not my idea. This is actually an idea that was floated by Tom Starzl, the father of liver transplantation, some 30 years ago. And this involves taking individuals who've been declared dead by meeting brain death criteria, who's wanted to donate their organs for the purposes of transplantation or research, who, after us trying multiple times to place their organs, for whatever reason, their organs were not suitable for transplantation, they were able to enroll in our study. And in this case, we removed the native kidneys and then performed the xenotransplants while maintaining this brain dead decedent on cardiopulmonary support. It's been known as the Parsons model after the first human brain dead decedent whose family enrolled him in this study. So what have we learned? Well, the first thing we were able to do was develop and validate a flow cross-match specific for pig to human. So here you're looking prospectively, meaning before the xenotransplant, and you can see that with Mr. Parsons, we projected a negative flow cross-match, and retrospectively, we confirmed it. We were able to validate this by actually doing the xenotransplant. So here we've removed Mr. Parsons' native kidneys. We've used immunosuppressant medications that we routinely use in human-to-human allo. You can see them listed there in terms of induction and maintenance therapy. Here's a picture of the pig kidney prior to reperfusion. And here's a picture of the pig kidney immediately after a reperfusion, showing it being beautiful and pink. This is a Doppler probe where we're listening to signals. And we observed no hyperacute rejection over a 3-day study. And you can see that kidney is beautiful and pink. It did not turn black and hyperacutely reject. And so we were really excited about this finding. We wanted to understand how good was our immunosuppression that we gave, that FDA-approved immunosuppression that we use in human-to-human transplant. Was it good in pig-to-human? And so we wanted to assess something called the adaptive immune system that involves our T cells and B cells, and we leveraged single-cell technology to do it. These top two markers are markers for human T cells. The bottom marker is a marker for human B cells. Here you're looking at the pig kidney prior to implantation. And the lighter the color, you see the presence of T cells and B cells. But you can see by day 1 through day 3 and then day termination, you can see there was really no presence of human T cells or B cells. And that's really great. It suggests that the medications we gave, which were designed to deplete T cells and B cells, worked, and that they were able to work on a pig kidney just like they do a human kidney. But we did, however, observe what's called TMA, or thrombotic microangiopathy. And here you're looking at pathology of the pig kidney prior to sewing it in. You can see here, this is light microscopy. And then we're looking for something called C4D staining on immunohistochemistry. This is a complement protein. You can see after the xenotransplant was performed, you can see this presence of these red blood cells where they're not supposed to be. And this is evidence of thrombotic microangiopathy. And this occurred early on day 1. And it was read as C4D negative. All this staining is non-specific, meaning we did not see complement deposition. And when we looked at immunofluorescence on day 1 and day 3, we didn't see any antibody or complement deposition. And so this was really interesting that we were observing this thrombotic microangiopathy, but in the absence of antibody or complement deposition that we had been able to detect. And this is striking because typically when you see thrombotic microangiopathy this early after a transplant, you worry about a severe and aggressive form of antibody-mediated rejection. So we wanted to understand what could be causing this. The first is, were we seeing thrombotic microangiopathy as a result of brain death physiology? We know that complement gets activated in the setting of brain death, and so we wanted to understand if perhaps the innate immune system had been activated. If it was, we should be able to detect something called the membrane attack complex, which is the terminal component of complement, and it can be activated through the alternative cascade. And if that happens, we wouldn't have seen other earlier elements of the complement cascade. So here you're seeing a positive control and a negative control for MAC staining, and this is the decedent's native kidneys, and this was read as negative for MAC. So we don't believe that brain death physiology was driving what we were seeing in the xenograft itself. We also wanted to understand if perhaps it was associated with some of the maintenance immunosuppression therapies we had given, specifically calcineurin inhibitors or tacrolimus, as these have been associated with the development of thrombotic microangiopathy. But on day 1, we actually had not started our tacrolimus yet. And remember, we were already seeing thrombotic microangiopathy. And so it's unlikely that the CNIs were responsible for this. The other question is, perhaps our human transgenes that we thought we inserted weren't really there. And so we did staining for this. And so CD46 and decay accelerating factor are human genes that are designed to help regulate and control complement. And here you're looking at positive and negative controls, and then pictures of the pig kidneys themselves. And you can see that there's expression of both of these complement genes. However, we know that these complement genes are really designed to control the classical and lectin pathways of complement, not the alternative cascade, which can actually be activated by the innate immune system rather than the adaptive. And so we're thinking that perhaps that was what was going on, and we wanted to study it. So again, we leveraged single cell technology. In this case, instead of looking for T and B cells that are a part of the adaptive immune system, we looked for innate immune cells like macrophages. And you can see, compared to pre-transplant all the way to day 3T, you can see we were able to detect both pig macrophages and, importantly, human macrophages. And in the graphic below, you can see that brown dotted line starting to increase with human macrophages beginning to infiltrate the graft as early as between days 1 and 3. And then importantly, when we looked at MAC staining in the xenograft itself, it was positive, suggesting in fact that complement had been activated, likely through the innate immune response through the alternative cascade. And so we believe in fact this was evidence of an early xenograft rejection, and such that our current immunosuppression protocol was not sufficient. So with this, we believed that we needed to introduce a complement inhibitor. And so we introduced a complement inhibitor to inhibit at C5 to prevent the formation of that membrane attack complex. And we introduced eculizumab. And you can see that by doing that, our histology was absolutely pristine all the way to the end. There was no evidence of membrane attack complex all the way through day 3 until day 5 when our eculizumab levels fell below therapeutic. Importantly, we did not see any evidence of thrombotic microangiopathy. And in this case, that was despite actually having therapeutic tacrolimus levels, as you can see here. So all this to say that we have, in fact, now identified an appropriate immunosuppression regimen for pig-to-human xenotransplantation that involves the use of FDA-approved standard immunosuppression medications. This complement inhibitor that I described is something that we use routinely when we transplant patients who have a condition called atypical hemolytic uremic syndrome. So we were really excited about this, and it's important to note that our colleagues at the Massachusetts General Hospital used a similar regimen in their recent successful transplant into a living person. The next question we wanted to answer was whether or not pig kidney physiology could actually support a human. It's important to note that kidneys do much more than just make urine, and we needed to understand if they could actually support human adult physiology. One of the things our kidneys do is they help us maintain our blood pressure. And what we were able to observe is that there was, in fact, hemodynamic stability after our xenotransplant. So this is a human decedent who actually was on continuous renal replacement therapy or a form of dialysis. This was stopped, the native kidneys were removed, and the xenografts were transplanted. And you can see hemodynamics were maintained throughout that. That's a really good sign. We also were able to demonstrate no issues with high potassium. So here's our potassium while on before dialysis was initiated. Then after dialysis was stopped and the kidneys were removed and the xenograft was transplanted, you can see that the potassium levels remained in a normal range. That's great news. You can also see that our urine osmolality increased, suggesting that the pig kidneys have the ability to concentrate urine, all of which is super important. We also were able to test something called the renin-angiotensin-aldosterone system. And this is one of the things our body uses to help maintain and manage blood pressure. And I want to draw your attention to a couple of things. One is the plasma angiotensin 2. And so we think that maintenance of blood pressure, along with measured levels of angiotensin 2, suggests residual RAS activity. Moreover, we were able to detect aldosterone, again, suggesting residual RAS activity. And so we think these pig kidneys are going to provide sufficient RAS activity to support an adult-sized human. We also wanted to understand whether these pig kidneys could handle hormone signaling. Our kidneys have to do that. They deal with hormones like insulin and parathyroid hormone. So here you're looking at parathyroid hormone that helps us manage our calcium and phosphorus. And you can see that the parathyroid hormone levels followed the ionized calcium levels appropriately. We did have to give some calcium throughout the study, but nonetheless, the parathyroid hormone levels responded appropriately. It is important to note that we did note that the serum phosphate levels remained high, but that this in fact was not due to impaired urinary excretion. In fact, the pig kidneys were able to excrete phosphate normally, so that was good news. And then at the end of the study, we were able to introduce a phos binder and were able to control our phosphorus levels just like you do in a human-to-human allo transplant. We also were able to demonstrate life-sustaining clearance of both endogenous and exogenous substrates. So on the left, you're looking at serum creatinine. So this is our decedent coming off dialysis and having the native kidneys removed. We then transplanted the pig kidney, and you can see the blue line is the serum creatinine, and it fell like it should with a nadir at 0.8, and on the final day of the study, it was 0.9. Correspondingly, the creatinine clearance as measured by 24-hour urine collection increased appropriately. We also demonstrated inulin clearance to be over 200 cc's per minute. So all great news that these pig kidneys work well in a human model. Here's another graphic showing you the 24-hour urine collection. You can see the creatinine clearance here, as well as the inulin clearance. And it's important to note that it was more than sufficient. The pig kidneys had creatinine clearance of over 200 cc's per minute. Again, as a reminder, a living person can be a kidney donor just simply by having a creatinine clearance of 90 cc's per minute with 2 kidneys, so more than sufficient. It does appear that our current estimating GFR equations are not going to be accurate in the setting of pig kidney transplantation. We also looked at pharmacokinetics of various medications that might be necessary. This is looking at a common antibiotic called vancomycin, and we looked at the AUC and MIC. And what I can reassure you is that the pig kidney is able to handle these renally clear medications just like human kidney transplants are. So great news there as well. We also wanted to look at kidney salt and water handling. We did observe loss of free water. In the first 24 hours, the pig kidneys produced 37 liters of urine, and our serum sodium went up in response to this. But with fluid resuscitation, as well as exogenous desmopressin, we were able to get the serum sodium levels back to normal, where they were maintained throughout the course of the study. And importantly, we were able to calculate the urinary water loss, which we're anticipating about 3 liters per day, which is about how much a human recipient is going to have to drink to ensure that they don't dehydrate with these new pig kidneys. We also looked at something called aquaporin, and that's a really important indicator that the pig kidney can actually respond to human antidiuretic hormone or human vasopressin. And what we are able to demonstrate in these pictures is that the aquaporin appropriately translocated, suggesting that the pig kidney is in fact responsive to human vasopressin. And so we don't anticipate issues with water or salt handling in these human recipients. We also demonstrated maintenance of electrolytes and acid-base status. Here on the left, you're looking at serum magnesium, showing within normal limits between the red bars, and then our serum bicarb on the right. What is important to note is that the pig kidney does not appear to be able to make erythropoietin, and so these patients, if they suffer from chronic anemia, may need supplement with exogenous erythropoietin to maintain their blood counts. The next question we wanted to really assess is around product integrity. And this is really important because non-human primates, when they, in the studies that have been done to date, have been on the average of 10 to 15 kilos. And so as a result, have very low resting systolic pressures. And we wanted to know if these pig kidney vasculature could maintain its substance in the setting of adult systolic resting pressure of a human. And so you're seeing here these systolic blood pressures in the 3 decedents, and you can see they're much higher than they are in a typical non-human primate or a pig. And importantly, these pig kidneys were able to maintain both parenchymal and vascular integrity. Here you're looking at parenchymal integrity. This is a subcapsular hematoma that had to be evacuated. We had to actually remove the capsule of the kidney to prevent page kidney. So here you can see the pig kidneys with the capsule removed. Despite not having a capsule, we were able to biopsy the kidneys multiple times. All these little black areas are where we've charted to control bleeding. And despite all of these multiple biopsies, there was no fracture of the pig kidneys parenchyma, which is great news. And then importantly, we were able to implant these kidneys both singly and in block, and we did not observe any issues with aneurysm formation or bleeding complications. And finally, around product release criteria, and there are several things that we're going to need to be able to confirm. The first is that we're going to have to demonstrate that there are no off-target effects, meaning that the pig cells don't go somewhere they're not supposed to. Here on the left, you're looking at a Western blot, and you can see this thing that I have highlighted is PRPL4. That's a pig ribosomal protein. You can see our wild type pig here, pig positive, and the 10 gene edited pig labeled as pig negative are positive for this. But you can see our human decedent recipient's blood was negative. So no evidence of pig cells where they shouldn't be. We took this a step further with single cell technology and looked at distant organs, and you can see there were no pig cells in the heart, liver, lymph node, or small bowel, again, reassuring that pig cells are not going where they shouldn't. We also need to understand disease transmission risk. I'm sure people are familiar with the heart case at the University of Maryland, in which porcine CMV was ultimately detected in the recipient's bloodstream. And as a result, they had to decrease immunosuppression and start treatment. The patient then suffered an acute rejection and ultimately passed away. And so we really need to understand this disease transmission. It's important to note that at Maryland, they did confirm the source animal pathogen status prior to procurement, but they did this only with PCR. And all PCR technology can do is tell you whether the animal is actively viremic, meaning there's virus actively circulating in the blood. It can't tell you about a past exposure, which is really important when the pathogen is a latent virus. And we'll come to that in just a second. The other thing is that the animal came from a biosecure facility rather than a true pathogen-free facility. So why is viral latency important? Well, porcine CMV is a latent virus, just like human CMV is. And viral latency is a type of persistent viral infection in which after you're initially infected, proliferation ceases, meaning you don't detect virus circulating in the blood, but you never eradicate the genome. And so it can rear its ugly head in the setting of being immunosuppressed. The classic example is the chickenpox. It's a herpes virus. We get it as kids. It goes away, and then as adults, we end up with the shingles. That's an example of a latent virus and how it can cause disease at a later time. And that's what happened in the case at the University of Maryland. And so what we recommend is that release criteria should include serologic testing of the animal along with the virologic testing, but we also think you should test the actual kidney tissue itself. So we've developed that workflow. And so here is us developing the porcine CMV serologic testing to ensure that the pigs have not had prior exposure to porcine CMV. We've also leveraged our single cell technology to develop a rapid workflow to take a piece of kidney tissue, a sort of a needle biopsy, take it to our lab, be able to assess that tissue to ensure that there are no zoonoses prior to that pig kidney ever leaving the pathogen-free facility and being transplanted. So again, really important things that we've been able to answer. And importantly, we were able to confirm this. We did not see any evidence of PERV transmission to our decedent. On the left, you're looking at the decedent's blood here on Western blot, and you can see that it's negative. On the right-hand side, you can see the blood pre-transplant and post. There were a couple of pig cells. They were PERV-C negative, but they went away at day 3. This is just an ischemia reperfusion injury where you just see dead circulating cells. And importantly, none of those cells made it to distant tissues. And as I mentioned, they were gone relatively quickly after transplant. So no disease transmission actually occurred. And so to summarize this sort of, I think I did this quite quickly, but hopefully this was super helpful to you. But some of our summary recommendations as we think about moving towards phase 1 clinical trials, we think there's diminishing returns of testing the 10-gene edited pig kidney in a preclinical xenotransplant model, and that we should move forward with phase 1 adaptive clinical trials where you do a transplant, you learn from it, and then make any changes necessary before you do the next transplant. We also think that xenotransplantation should adhere to industry standards that already exist in human-to-human allo. And what do I mean by that? There should be a prospective flow crossmatch to ensure tissue compatibility before proceeding. We should perform both serologic testing and screening of the source animal for latent pathogens, as well as product testing of the U-kidney to ensure that no disease transmission occurs. We also think that we should be using FDA-approved standard immunosuppression. There's no reason to use non-FDA-approved medications. And then we do believe that porcine physiology is different than human, but that it does in fact provide life-sustaining renal function and is appropriate for use in living persons. And with that, I just want to thank my entire team. It's certainly a team sport. I couldn't do it without all of these extraordinary people, and looking forward to our conversation at the end. Thank you very much.
Thank you, Dr. Locke. And with that, we'll turn the floor over to Dr. Marino, and we'll let him begin.
Great, thanks, Bill, and thanks for letting me be part of this conversation. I'm not going to talk for very long because I see there are already a couple of questions in the chat. I don't want to get in the way. I also want to congratulate Dr. Locke and, as she said, her whole team for what they've been able to do and how they've been able to move forward. And an idea that's been around since the 1960s. I wasn't teaching in medical school in the 1960s, but I have senior colleagues, retired colleagues who said, when I told them I was doing this, they said, well, I remember this idea from the 1960s and something that has taken a long time. And we, of course, hope that Mr. Slayman has success with this new kidney, that it doesn't get rejected. I would be interested in hearing what Dr. Locke has to say about her worries about his course, but we'll come back to that. No matter what happens, it's going to be a while before this approach scales up, right? So I want to say just a couple of things about what's going on in Washington. Dr. Locke sort of alluded to this, to try to improve the system. The United Network for Organ Sharing has been around since 1984. The last time I looked, which was just a few days ago, 28,000 organs donated organs are thrown away every year because of the inefficient organ transplant system. It's hard to find somebody who thinks that it's going well. The waiting list keeps growing. We're around 100,000 now from 40,000 a decade ago. There's a big supply-demand gap. And yet in this country, we have, unfortunately, lots of people who could be donors because of opioid abuse, because of motorcycle accidents and so forth. So it's got to get better. Now, the Organ Procurement and Transplant Network, OPTN, is being investigated by several congressional committees. There's been growing dissatisfaction. The Senate Finance Committee finished a several-year investigation that documented 70 unnecessary deaths after organs managed by an OPO had been abandoned at airports, if you can believe it, had never picked up or mistakenly discarded. A lot of this is being laid at the door of the network's computer and information system, which is supposed to match recipients and donors. I think everybody who follows this believes that it's way outdated, it's mismanaged, it's not secure, and around 6,000 people, according to the Senate committee, die a year waiting for transplants. So the Biden administration has announced plans for an overhaul of the agency that gives contracts to UNOS and to the 55 organ procurement organizations. A new dashboard is needed. And so there's going to be a lot of competition and there is now a lot of competition to try to replace UNOS and do better than UNOS. This is one of the few things that this Congress actually seems to be able to do something about. One can be hopeful. On the Senate side, Senators Grassley and Wyden are asking for answers from UNOS about a data breach. And so, there's a lot of problems with the system. UNOS is responding. They are under a lot of pressure. They're trying to clean up their act. They recently revamped the way that they handle patient data. They are looking at according to some reports, they're looking at better ways of getting hospitals to be race neutral in their testing. Dr. Locke actually alluded to this problem. Black people in this country are much less likely to receive a kidney than white people are. So, there's a lot of work to be done. And hopefully within the next 2 or 3 years, there will be a better system. I'm going to stop there with my remarks because we don't have much time. I do have a couple of questions for Dr. Locke, though. And then perhaps, Bill, we can turn to the questions in the Q&A. So actually, I have kind of an historic question for you. 30 years ago, I worked at Downstate Medical School with a colleague named Peter London. And Peter London, when he was a medical student at Downstate in 1971, testified before the House Ways and Means Committee. And they were looking at, if you can believe it, universal health insurance at the time, but they got interested in end-stage renal disease, and it's led to the dialysis appropriation that we still have. Peter was a very interesting person. I don't know if you've ever heard of him, but he became a nephrologist at Downstate, and he wrote about his decision never to get a transplant. And people were puzzled by it. I was puzzled, and I distinctly remember sitting in front of him having a conversation about it. This would have been the early 1990s. He died in 2001. And he explained to me that he had another idea. And the other idea, which he did for a few years, was renal replacement therapy. Can you say something about, does anybody think that renal replacement therapy is a viable approach anymore? Or I'd love to hear anything you have to say about it. I don't want to spring it on you, but it's something I've thought about for a while.
No, it's a great question. So I think there are definitely individuals who are looking at how do you design renal replacement therapy that can work 24 hours a day, 7 days a week. So this concept of wearable devices, because I think that's
Yeah.
really the rub. Our kidneys, my kidneys are functioning right now. I don't really think about it. They're doing all sorts of things, but importantly, one of the things they do is clear my body of toxins,
Yeah.
which really reduces my cardiovascular risk, because uremia is terrible for all sorts of things. The problem with dialysis is you're trying to get what the human body does 24/7. You're trying to cram that in to either 2 to 4 hours, 3 to 4 days a week, or overnight if you're home hemo or PD. And so it just can't keep up. And so I don't think that renal replacement therapy, unless it can be something that can be done 24 hours a day, 7 days a week, and keep the individual mobile, because if you have to be tethered,
Sure.
you can't really live. And so there are folks working on that. I think it's an interesting alternative. But until that comes to fruition, transplantation trumps dialysis every single time. And that's the reason why, because a transplanted kidney can work around the clock.
That's very interesting. Thank you. You kind of closed a circle in
Yeah.
my experience
Yeah.
with this colleague. And so one other question. You mentioned the idea of synthetic kidneys. A long time ago, when I was still at University of Virginia, I spent a few days with the group under Tony Atala at Wake Forest.
Yeah.
And
I
they were
know.
printing a kidney, or he proposed to print a kidney using a printer that's not unlike the inkjet printer I have on my right in my study here.
Yeah.
And it was a very interesting idea. They, instead of ink, they had cells. And as you may know, that he got a lot of attention because he was able to hold this thing in his hand, right?
Yeah.
But as I understand it, and I'm happy to be corrected, I gather this is the case. They were never able to really get the internal workings of the thing. I mean, it looked like a kidney, it talked like a kidney, but it didn't work like a kidney.
Yeah.
Right? So where does that stand? The idea of printing a kidney?
So there are groups actively working on it. You're correct that that problem hasn't been solved yet, but I know that there are a lot of people working on a synthetic kidney, so kidneys that can actually be made that don't even require human cells per se. There are kidneys that are using animal scaffold. So they take an animal organ, they digest off all the animal cells and just have the scaffold and then are repopulating it. There are people looking at organoids and growing things in dishes. I mean, I think people are looking at all of those things. And I think it's really important, right? Because it's sort of like, we're not going to just stop at this animal source. It's like, because the ideal thing would be if no human or animal ever had to be a donor again, and we could actually manufacture this thing. And so I think that's where the field would love to eventually get. I think that's much, much further down the road than where xenotransplantation is right now.
So I love that you mentioned organoids, because I'm very interested in what are sometimes called cerebral organoids or brain organoids, and of course these are now lab models of cells from induced pluripotent stem cells that can be grown, and they self-organize, and you can do lots of organs. I'm especially interested in brain stuff, but
Yeah.
as you say, it could be other solid organs as well. Do you see organoids? I mean, how is that going to work? Xenotransplantation right now is a term that's being used for putting, say, neural organoids into rodents in the laboratory. And that itself is an ethics conversation that we can have separately. How do you see that playing out with kidneys? I mean, are you going to grow kidneys with organoids, or are you going to replace partial parts of the kidney with an organoid, the way we hope that embryonic stem cells would do that 20 years ago?
Yeah, I mean, again, this is my own personal bias. The truth is, I don't know that I know the answer that anyone does, but I could see it more in a therapeutic. So like, for example, you've got someone who has FSGS, right? And that's a recurrent disease. So transplantation oftentimes does not solve that problem because it can recur in the transplant. Could you leverage something like an organ to like actually fix that component? So those types of things, but I don't actually know. Is there a way to heal the foot process effacement? Could you somehow do that? I don't know. It'll be interesting to see, but I think there are endless possibilities. And then, of course, I think organoids play a unique role in testing various therapeutics as well. So as we expand into xenotransplantation, we're going to need new medications that we've never used before. And so I think organoids offer a unique opportunity to be able to study that and limit the number of animal studies that are needed.
Yeah, I mean, it's a fascinating wet lab model.
Yeah, for sure.
It's really really interesting. So I have one last question for you, and then maybe we can go in the Q&A with other folks. What, as you think about Mr. Slayman's course, the gentleman who received the organ 3 weeks ago, I guess now at Harvard Mass General, is there anything besides the obvious, which is rejection for some reason that we don't, you and your colleagues would at the moment don't understand or don't anticipate? Is there anything that worries you besides that?
Yeah, I mean, I think we've demonstrated that pig kidney physiology can absolutely sustain an adult human, but there are things that I think you're going to have to watch out for in a human that has a pig kidney versus a human kidney. So one of them is the voluminous, I can never say that word, but basically high output.
Voluminous, is that the one
Thank you. Yes, that's it. Urine output. And part of that is that the pig kidney, although it has functions similar to a human, the loops of Henle are actually much shorter in a pig than they are in a human. And so as a result, a pig kidney's ability to concentrate is a little bit different. So one of the things that will be really important is watching out for dehydration and whether or not that could impact blood pressure and other things. Those are things that we watch out for in human to human as well. But I think with a pig kidney is going to be something that requires a slightly closer eye. And then I think what I'm really curious to see are things as this moves out longer term. Will he become sensitive? Will there be cross reactivity such that he becomes sensitized to future human allografts? So we don't know. There is a lot of species homology between pigs and humans, oddly enough. And so the question is, can exposure to a pig organ sensitize you to future human organs? And then the $1 million question, is this going to be destination therapy, meaning this will last him the rest of his life? Or is this going to be a bridge to when perhaps another human allograft becomes available for him? And those are the kinds of things that are going to take time. I know lots of folks are worried about zoonoses, and perhaps I'm naive in that regard, but I worry a lot less about that. I think I think as long as that pig kidney came from a pathogen-free facility and they had negative serologic and PCR testing, I really worry a lot less. I think in many ways we know much more about the pig donors than we ever know about a human donor in terms of where it's been from start to finish and what it's been exposed to. And so I have a lot of comfort around that. And then, I think so that for me is less of a concern, and it certainly will need to be monitored for, but I don't perceive that that's going to be an issue.
I have to say, I'm tempted to ask you the evolutionary biology question of what's the advantage of the difference between the pig kidney and the human kidney, but who knows?
I think only time will tell.
Darwin rolls the dice. Yeah,
that's right. Unclear.
Yeah. Bill, we could keep chatting, but that's all I got. So for the moment,
okay. Well, we have a few questions that are actually quite good, and I think you're largely off the hook, Jonathan, because
yeah, I've got to run to a much less interesting session, a department committee meeting. So
yes,
Mazel tov.
Death and taxes on department committees.
Thanks so much. It's great to meet you. Yeah,
great to meet you. Thank you. Thanks for what you're doing. Thanks to your team.
Absolutely.
All right. Well, the first question we have is why stop at kidneys? The list of transplant deficit organs is extensive. Also, is the pig sacrificed at the OR table, which would expect that more viable organs would be available if so.
Yeah, great question. So yes, to all. So there's lots of work going on with all the organs. I mentioned the University of Maryland has done a heart transplant. Jonathan's colleagues at Penn just used a pig liver to help with acute liver failure. So that's off to the races. The kidney work, I think lung will be kind of after everything else. It's a little bit more challenging of an organ. But the answer is yes. And I think the ultimate goal would be to have one pig donor be able to save countless lives, not just one. And yes, the pigs are humanely put to undergo anesthesia. The procurement occurs and they're humanely euthanized at the end of that. But to your point, the kidneys, because of that, really do function very much like a live donor transplant. So you're spot on, and we expect the outcomes to be quite good.
Okay. Another question is, in kidney transplant recipients whose disease is due to long-term diabetes, a pancreas transplant is sometimes done concurrently. Has this been considered with recipients of pig kidneys?
Yeah, I think people are certainly thinking about it. The majority of the work that's been done around xenografts with regard to the pancreas has really been around pancreatic islet cells. There's a great experience out of New Zealand in which they've transplanted islet cells from genetically modified pigs and cured diabetes. And so I think there's a lot of interest in that. And so people are studying that as well.
Yeah, I have friends who have once had a kidney transplant, and it came from a relative, and it's been very successful for her. Another friend has had a lung transplant, and apparently the immunosuppressant regime he's gone through has continually been at the hospital with multiple infections. I don't know if there's a difference there.
Yeah, lung transplantation is hard. So there's probably no other organ that has more contact with the external environment than the lungs because you breathe air. So the lungs are constantly getting exposed to external things. So external bacteria, you walk by, somebody sneezed 2 minutes ago and you still are getting that in, right? The kidneys, liver, yes, technically the liver makes bile and that's connected to your bowel, and the kidney makes urine and that's connected to your bladder, but you don't see as many infections. They're not constantly exposed to the external environment. Lung transplantation is constantly exposed. And so it's a challenging organ in transplantation in general. I think in the setting of xeno, it's going to be even more challenging.
Yeah, interestingly enough, my friend with the lung transplant has had as much difficulty with his original lung than with the transplant one.
Yeah. I mean, the lungs are a tough spot, right? I mean, we're constantly getting exposed to yucky stuff in the air. So the lungs struggle.
Okay. And I guess, have you had any pushback from things like PETA that you're sacrificing pigs to save humans?
I mean, I think PETA has certainly put out several things, but I think in general, the main thing is wanting to ensure that the animals are cared for appropriately, and they absolutely are. These pigs are cared for better than anything you've ever seen. I mean, it's amazing the environment in which they get to live and prosper. It is stark contrast to what you may think of when you think about sort of the food chain. It's completely different.
Mhm. You should have to raise them in a sterile environment and keep them.
Yeah, I mean, and you really do. And they have environment enrichment. They like listen to NPR. They have like toys they play with. They get hoof massages. They're actually vegans. The pigs are vegans, so they don't receive food with any animal product at all. And so it's pretty amazing the links that we go to ensure that the pigs have high quality care and are just well taken care of.
How many facilities are involved in raising the pigs?
There are very few facilities across the country. To my knowledge, there are 3, I believe. And so that'll be something that has to be addressed as people look to scale this up.
Yeah, kind of a supply and demand issue
Yeah,
that if there's no demand, nobody's going to make pigs.
yeah, fair.
And I'm sorry about that.
No, that's okay.
I don't have any other questions from the audience. Is there any closing remarks that you'd like to make?
Just want to say thank you. Enjoyed getting to know you all, and thank you for taking interest in this. I think it's here to stay, and onward and upward. We have a lot of folks who need help, so hopefully we can push this over the finish line.
Great. Well, thanks to you and to Rowena, and no thanks to the cat.
All right, y'all have a great day.
And
Thank you.
just want to remind you that we'll be back for our next season in September of 24. And I want to thank everyone from the committee members to the speakers, and especially you, the audience, for being with us throughout this journey. And we look forward to seeing you in September. Take care.